So thank you for joining us today for a special webinar Wednesday. Today's topic is what is smoldering MS? This webinar is brought to you by Can Do Multiple Sclerosis. My name is Laura Allen. I'm the Director of Programs at Can Do MS, and I will be your moderator this evening. I would like to thank our generous sponsors for supporting this webinar. Thank you so very much. Our speakers this evening are Roz Kalb, Gabriel Pardo, and Marie Moore. Roz is a clinical psychologist and a senior programs consultant at Can Do MS. Good evening, Roz.
Hi, it's good to be here, Laura. Thank you.
Gabe is a neurologist and the director of the MS Center at the Oklahoma Medical Research Foundation. Hi, Gabe.
Good afternoon, good evening, Laura, and everybody that is listening in.
Marie is a nurse practitioner at the Novant MS Care Center in Charlotte, North Carolina. Hi, Marie.
Hello, and thank you for having me.
It's great to have all of you. So thank you for being here, and thank you to all of our participants for joining us. And with that, I would like to turn the meeting over to Roz.
Thanks very much, Laura, and welcome to all of you. This is such an interesting topic, and I'm thrilled to have Marie and Gabe here with us tonight to help explain it. So I'm going to start by asking Marie a tough question. So people in the MS community may not have heard the term smoldering MS before. It's pretty new in the MS world, but many are familiar with the experience. I'm sure you and Gabe have both heard patients say, and I've heard patients say, my MRIs are stable and I haven't had any relapses. So why do I feel worse? Why is my MS progressing? Can you help explain that?
I'll try. And I will say that this is something that we've been hearing for years in clinics. So this is not new, but I think our understanding of why some of this is occurring has begun to improve. And I feel like we have to go back a little bit before we can really talk about this. When we look at where we've come over the last 30 years with treatment, when I first started treating MS in the early 2000s, we did not have the ability to completely control relapses or new lesions. Patients continued to have relapses and ongoing evidence of disease or inflammatory disease despite being on therapy. But over the last 10 to 15 years, we've really seen a turn in that. We've really improved our ability with the numerous therapies that have come out to control new relapses and to control new MRI lesions. And with that, one might think that we should have been able to really control the disease, but that's not been the reality for all. I do want to point out, though, that there are some patients who are on therapies and they really are well controlled. They are not seeing any kind of disease progression. They're not seeing relapses. They're not seeing new MRI lesions. They are really doing well. But I have another group of patients, though they don't have new lesions, though they do not have new relapses, they're still seeing this slow, steady progression of disability. They're getting slightly worse on their ability to walk, for example. Maybe their cognition is slightly worsening with time. So when we look at this graphic, what I'm explaining is over on the right-hand side, PIRA. PIRA stands for Progression Independent of Relapse Activity. And this can occur despite the fact that on the left-hand side, that acute inflammation is controlled. And that is really what we're going to be talking about this evening and trying to better understand. And our understanding of this is that we are seeing what we would call smoldering inflammation or inflammation within the central nervous system, the brain and spinal cord, that's occurring at a level that we really don't see on any of the testing that we currently have available in clinic. But we know that it's happening, and we're going to talk a lot more about that this evening.
Awesome. Thanks, Marie. So Gabe, how is this concept of smoldering MS different from the way we've thought about MS in the past, or how we've talked about secondary progressive MS? How does it fit with all of that?
It is more of an explanation of what we have already been recognizing and witnessing for a long time. So it's the evolution in the knowledge of what is happening in the mechanism of disease, what is happening in an individual that has MS that is giving them problems, right? And we continue to improve our knowledge and we continue to improve our understanding. And this is the answer for some of them that are experiencing that progression. As Marie very clearly explained, we have recognized that when we look at patients, we can assess them just by how the disease has been evolving, and we have classically labeled that as being relapsing remitting MS or being progressive MS. And progressive MS, secondary progressive when they follow a period of relapses and remissions, primary progressive when it starts like that from the beginning and they never had an acute relapse. And that actually very neatly correlates with the two known mechanisms of disease. So what is happening in your body that creates the problem? One of them is acute inflammation. And we have known for quite some time that the basis of the problem in multiple sclerosis is that the immune system is malfunctioning, so to speak. Malfunctioning in the sense that its purpose is to defend us from things that do not belong in our body. Usually those are pathogens like bacteria and viruses, things that cause illnesses, and we can identify them, destroy them, and get rid of them, and we remain healthy. But in MS and other autoimmune diseases, the immune system gets confused and starts attacking parts of your own body. In the case of MS, the target of that attack is myelin, the insulation around nerve cells. When the immune system that is free-flowing in our bloodstream, surveying, making sure that we identify any pathogens, like the police kind of, on street beat, trying to see where there are bad guys around and trying to arrest them. The immune system is doing that. And periodically, it gains access into the brain. It goes in, and then it gets confused, recognizes myelin mistakenly as something that needs to be destroyed and creates the damage. That is the acute inflammation. We have an acute event. The immune cells come in. There's chemicals that enhance the inflammation, there's destruction of the myelin, there's damage to the nerve cells, and individuals experience an acute relapse. I'm fine today, tomorrow I have blurry vision, progresses over a day or two to no vision. I had an optic neuritis as a relapse of my MS. So that acute inflammation is driven primarily by what we call peripheral immune system, the one that is free-flowing in the bloodstream. But we have also recognized that in addition to that acute inflammatory activity causing relapses, and we witness that when we do MRIs as new lesions, the white spot that we have in the brain, that there is a second component that we have called, as you just mentioned, Rose, progressive disease. Patients continue to slowly worsen. Is it the same process causing that, or is it a different process? And what we have recognized is that indeed it is a parallel process. Both are happening at the same time. If one induces the other or conditions the other, we do not know for a fact. That's something that still needs to be elucidated, but they are taking place, and both of them are responsible for accumulation of disability. One acutely, and if you do not recover completely, you are left with a deficit. The other one by building up slowly over time that deficit. That second process of progression is driven by a couple of mechanisms as we understand it right now. One of those two, is the smoldering inflammation. And this has come as the result of recognizing through different types of studies, like looking at pieces of the brain under the microscope or doing some special techniques with the MRI, that there is persistence of low-grade inflammation at the edge of the lesions that we have had as a consequence of the acute events of inflammation. Now, that's not the only reason through which individuals can accumulate slow progression. There can also be a component of neurodegeneration.
So let me interrupt you for a second. And Laura,
Yes.
could you put that first slide back up to remind people where the neurodegeneration and the smoldering MS are? Yeah, okay, thank you.
Exactly. So Here in the graph on the left-hand side, you have the acute inflammation that I was referring to, relapses, MRI lesions that we identify. On the right-hand side, you have what we have now labeled as PIRA. We like to give funny names to everything, right? And PIRA is just a descriptive name, progression independent of relapse activity. So relapses are on the left-hand side, but if you're not having relapses, can you still worsen? Yes, and that we are calling PIRA. And PIRA can be, as you see here, due to either a smoldering inflammation that can continue to chip away on the normal brain structure, or it can also be a process of neurodegeneration that we need to understand better, but for which we have some hints of why it might be taking place. Now, those are very important, as you can see here, but not the only ones that we'll discuss later on. What are the other elements that can also contribute to this? All that to say that even though smoldering inflammation is a new concept, we're calling it that, it is just a complementary explanation to what we already knew was taking place, and the recognition that it is an area that we need to target with our therapies. Because as you well mentioned and Marie highlighted, our patients, even if we control very, very well for some of them, the relapses, the acute inflammation, some of them continue to worsen. Why is that? It can be smoldering, and then we need to do something about it.
So Marie, what evidence do you look for to determine whether this smoldering MS is the reason for a person's progression versus the neurodegeneration that you and Gabe have both talked about? How do you assess for it?
So it's a great question, and I wish I had a simple answer for you, but I don't have a simple answer for you. The first thing I'll say is, as Gabe was explaining very eloquently, what we have begun to see as our understanding of MS has grown is that when we look at brain, pieces of brain under the microscope, when we have in research institutions high-powered MRIs, those lesions that we can see on a brain MRI that anybody's MRI will show, if we look at them with different technology, we can see little bits of inflammation around the edges of them, or we can see them slowly growing. That's not technology I have right now available in clinic to see. And I think part of that will help us be able to definitively diagnose this in patients, but we're not there yet. So when I'm speaking with a patient and I'm beginning to suspect smoldering MS, it's really more of just a clinical suspicion. I don't have a way to diagnose it. And that's a really important point. But in my patients who are on highly effective therapies, who, again, the measures that we can measure are well controlled, meaning they're not having new relapses, they're not having new MRI lesions, yet we're still seeing some disability progression. Those are the patients that I'm beginning to suspect that this may be occurring with them. Certainly, we're going to look at the other lifestyle things that can also contribute to disability progression. And that's a really important thing that we'll drill into a little bit later on this evening. But this is one of those concepts that does begin, I'll begin having the conversation with the patient saying, hey, I kind of suspect this. But it's a little bit of a, hey, I suspect this, stay tuned. I don't have a way to really treat it just yet, but we're getting close, I hope.
So if I'm understanding what you're saying correctly, the standard MRI that you two use in clinical practice doesn't show this. So you're relying on what your patients are telling you about how they're feeling, what you're picking up in the neurologic exam, and your clear impression that they are progressing in spite of the fact that you think that the DMT they're on is working very well to control that acute inflammation. Have I got that right?
Yeah, I mean, it's crazy. After all these years, we're coming back down to just really listening to our patients, right? I mean, that's so important. But I also want to make the point that if patients weren't on those DMTs, and if they were still having that focal inflammation, the relapses, all that other stuff, they would probably be in a much worse position than they are with the therapy. So the therapies are still doing a fine job of doing what they do, but we are just needing to kind of figure out how to better treat this aspect that we're only beginning to understand.
So Gabe, I'm sure that you've had patients come in and say to you, well, I've been taking this DMT forever. In fact, we've switched 3 times and I'm still progressing or becoming a little more disabled. Why bother?
Right.
So could you just reinforce why they need to continue to bother?
Absolutely, because this progression is not the only mechanism through which you can get worse. And we need to do all we can for the components that we know are continuing to be active and that pose a significant risk for even more disability. Yes, we're not ideally controlling the process because the progressive component might not be perfectly tackled. We have gotten so much better at controlling acute inflammation. With the highly efficacy therapies that we have nowadays, we're seeing a shutdown of that component. And that has resulted in much better outcomes. There is no doubt that they bring a lot of benefit in the early stages of the disease and as a prognostic element down the road. We see this in every single trial. Individuals that start on any treatment early on, much more on highly efficacious therapies, and we follow them over time. They continue to do much better 5, 10, 15 years down the road than those that did not start treatment early on or started no treatment or were on treatments that were of lesser efficacy. So we know that they work well, and they work now and they work for the future. So continuing those DMTs, disease modifying therapies, very, very, very important. But that is not the end of the story, and we recognize that. And this is just good news that say, hey guys, we've been listening. We hear you. We understand what's going on. And despite this very efficacious control of the inflammation, some individuals, a proportion of you guys, continue to progress. Why is that? So we're coming up with the answer of the understanding of that. And then also the possibility of being able to intervene in that component as well, and perhaps improve the outcomes even more.
A comment came up in the chat that I just need to bring up, even though it's a bit of a interruption in our flow here. But somebody said that the DMTs are not recommended for people with secondary progressive MS, and I didn't want to let that go by because I think that's not correct information.
Right.
Marie, can you comment on what we know about the current medications for progressive forms of MS, just to clarify that?
Sure. So I think the first thing to say is there's not a one size fits all to that answer. So I do want to make that very clear.
Yep.
And there are a lot of different things that have to be considered when we're talking about continuing a therapy with anybody who's on a therapy. But a lot of the DMTs have actually now been approved for active secondary progressive MS. And so we know that even though a patient has progressive disease, there still is a component of the inflammatory process that's there that we've got to control, because not controlling that will result in continued worsening. And I think that this really also is a good time to just discuss the fact that this is not these are not binary diagnoses. You don't have relapsing remitting MS one day, secondary progressive MS the next. This is a progression. This is a continuum. And we see this continuum from relapsing remitting into more progressive disease. But all along that way, we're wanting to control the parts of the disease that we can control. Gabe, would you like to add to that?
That's absolutely the case. We need to emphasize that, I don't know how many times tonight, that the disease modifying therapies make a big, big difference. They're controlling a significant component of a true mechanism of disease that leads to disability. We're tackling that very well. But there's more to the story. It's just that, there's more to the story.
More to the story. So another comment that came in, DMT is a disease-modifying therapy, which we hope you are on, and we hope you continue to stay on it while these doctors/researchers are looking for additional treatments to help slow progression. So back to Marie for a minute. The research that's been done on smoldering MS so far points out that MS disability begins to increase as people reach a later age. And we've always seen the more progressive phases later on, but it begins to increase at a later age, regardless of whether they were on a DMT or not, or what DMT they were on. We're seeing something that happens with age. So what does that tell us about the causes of disability progression?
So, and that's another really good question. In my mind, when I think of progression, like PIRA, this term, progression independent of relapse activity, I think of that as an umbrella. And there are a lot of things underneath that umbrella that can lead to that progression. Smoldering MS is one of those things. Certainly aging is another. Certainly lifestyle, smoking, different things like that also contribute to progression. Comorbidities, there's a lot of different things that contribute to progression. Aging is one of those. Anybody, MS or not, is going to not walk, jump, run as well in their 70s as they did in their 30s. That is aging, right? We all are getting slightly worse as we age. But in MS, we certainly see that as patients get into their 40s and 50s, you do tend to see more of that progression begin to kick in. So we know that aging is definitely a part of progression. But what's been interesting as we've been learning about smoldering MS is that those kinds of lesions that I talked about earlier, we call them cells, slowly expanding lesions. And pearls is another name for paramagnetic rim lesions, just fancy words for these changes we see on high-tech MRIs. We know that even patients, late in life, well advanced in secondary progressive disease, who had a lot of those kinds of changes on their MRI, more than 4 of those, they were likely to be more disabled than those patients, secondary progressive disease later in life, who didn't have those findings. So there is this concept that even with the progression that we know can occur with aging, there could be other factors that are influencing it even more.
So
Another
Laura,
concept.
can you go ahead and put up the second slide, please, Laura, so that we can see the timing of this? Gabe, do you want to comment on the timing here?
Yes, I think that's a very important aspect to highlight. And this is the fact that we recognize that this smoldering inflammation is happening throughout the course of the disease. The fact that we recognize it, or historically we have labeled it as such very late when we say, oh, you have secondary progressive MS, it is just a coincidental effect of timing and recognition of the consequences of that. But the process is happening from the get-go. And it is depicted here in that teal or light blue color, showing that from the very beginning, it is accumulating and slowly progresses. Now, time-wise, acute inflammation, acute damage tends to be more prominent in the early stages of the disease. When we start having MS is when we have more frequent relapses. When we're young is when we have more frequent relapses. And over time, naturally, the frequency at which relapses take place, the acute inflammation, tends to quiet down. And it's depicted here how it goes down over time. Now, both contribute to the degree of disability because you do not completely recover from acute damage that happens during a relapse. So you're building on top of that. So these are parallel processes that are taking place at the same time that start from the very early stages of the disease, but the smoldering inflammation, the progressive component, becomes more evident to the patients and to us as clinicians later on when it is more obvious that you are worsening despite the fact that everything else is controlled. And it has to also do with reaching a clinical threshold. That's a fancy term to say you eventually get to a point where it becomes quite evident because the brain, the spinal cord, the central nervous system has the ability to compensate for deficits, what we call plasticity or neuronal reserve. These are all terms to say, our brain adapts. We're putting roadblocks here and roadblocks there, and the brain finds a different pathway to fulfill the function and compensate for the deficit. But as other elements come into play, aging being an important one, then the brain is not able to compensate for that and becomes even more obvious. And that is when the progression becomes more evident to the patients. That's when we can quantify it. And that is, again, when it becomes labeled as secondary progressive MS. That is just the labeling of what we see later on.
So I want to go back to the first slide, Laura, because I think both Marie and Gabe have alluded to the fact that in addition to acute inflammation on the left part of the screen and the smoldering inflammation and neurodegeneration on the right that contribute to progression, there are these other factors, right? They've mentioned age, and we also see genetics and lifestyle and socioeconomic factors. So it's obviously a very complex process with a lot of factors affecting progression. Before I ask Marie to just address that for a minute, there's been an important question bopping around in the comments, and that's about whether people of a certain age should be stopping their DMTs. And from everything you're saying, again, that's a very individualized decision between a patient and their provider. But it seems to me that there's so much going on in the MS disease process that might still respond to one or another of the DMTs, that stopping might not be the best idea. So would you comment on that?
Sure. So there is this term called immunosenescence, which is a term that basically refers to the fact that as we age, our immune system does slow down. And in my practice, once patients get into that 7th decade of life, 8th decade of life, we really begin to look at their disease process as a whole. And if patients have been clinically silent for a number of years, meaning we have not seen new relapses, we've not seen new MRI lesions, and especially in those patients who may have mobility issues and are on strong immunosuppressant drugs, we do begin to talk about, is this the safest thing? Is there more reward than risk in keeping you on these therapies? And we will take their patients off therapies later in life for sure. This whole conversation regarding smoldering MS, that may change that as we better understand it. But as of now, we are making that change because a lot of the therapies we have these patients on, we feel can begin to result in more harm than benefit. But that's highly individualized. And that is by all means a process that is very individualized. And it is monitored closely. I don't know, Gabe, if you do the same thing, but that's how we're addressing that. And again, it's highly individualized.
Absolutely. That's entirely the case. Like everything that we do in medicine, in consultation with the patient, this is a dialogue that we put forth. Any intervention that we decide on doing is a consequence of analyzing the risk-benefit ratio. That means what are the benefits we're going to get from doing what we're going to do, being a medication or any other type of intervention, compared to the potential risks that we're assuming. Those can be safety or tolerability issues or financial aspects as well, right? And if there is more risk than good, well, it doesn't make sense to continue the intervention or the DMT in this case. And that risk-benefit ratio is not static over a lifetime. That changes as other factors change. An important one is age, because as we age, we have a lot of other things that come upon us. Comorbidities, meaning other illnesses that are going to compound problems or complicate how we use medications. You mentioned the aspect of immunosenescence, that the immune system becomes less active. But it's also something that needs to be seen in the context of our brain aging, right? And we have alluded to that earlier, that as we age, we see some more manifestations that are physical as a consequence of this process. We need to recognize that all of us, MS or no MS, undergo a process of brain atrophy, of shrinkage of the brain. We're losing brain cells all the time at a specific rate. If we were to quote things, we'll say it's a 0.1, 0.2% of the brain volume per year that is shrinking. But we do recognize that individuals that have had insults to the brain, like having MS that creates inflammation, it accelerates the rate at which we have that atrophy or shrinkage of the brain that compounds the problem of the progression. So that risk-benefit ratio analysis is dynamic, and that is why in certain individuals, when you reach the age of 60 or 70, your healthcare provider might start discussing, we might not be getting as much out of this than the risks that we're assuming. Shall we consider stopping treatment? That is a valid approach. For many others, it's like, no, we need to keep on treatment because we have evidence of persistent inflammation, and because we do not have comorbidities, and because we're not assuming additional risks, and it makes sense to continue the treatment. Very individualized, you're right.
So I'm a psychologist, not a neurologist, but what I'm hearing is that if you're seeing a provider who has a hard age cutoff, well, we stop treatment after 65, or we stop treatment after 70, that may not be a valid reason for stopping, because you as an individual patient may be progressing. You may be still having some inflammatory activity, even though you're 70. And so it needs to be considered with a little more individualized attention than some rule about an age cutoff. Is that fair to say?
That's absolutely fair to say. Now, an age might bring up the conversation, might bring up to the surface. You're 65, let's talk about it. And if we analyze the case, you know what, in your case, we should continue. That's your case. But it brings up the conversation. It's a valid point.
Mm-hmm.
Okay.
Yeah,
So,
I saw the DISCO MS study reference down there. Less than 10% of patients in their 60s and 70s who come off therapy would need to go back on it. But I mean, I just had a patient in clinic last week, mid-70s, new enhancing lesions off therapy. We put that patient back on therapy. It happens, right? So again, this is where that individualized care is so important.
Awesome. So Laura, can you go back to slide number 2? Because I think what we want to be thinking about now is what kinds of attention, what kinds of strategies, what kinds of medicine. No, sorry, go back to the first slide. Sorry about that. Yeah, so what kinds of interventions or treatments are we going to be looking at as time goes on? The DMTs clearly are doing a very, very effective job with the acute inflammation. So what are you two looking forward to now, both in terms of medication and in terms of other kinds of wellness interventions to address smoldering MS?
Yeah, I'm sorry, who were you addressing?
Go ahead, Marie. You start.
Okay. Yeah. So there are a group of medications in the pipeline that we're getting pretty excited about, and we feel like we may see an impact on smoldering disease. So these would be therapies that are targeting inflammation inside the brain. And that's a kind of a different way of targeting inflammation than what we've been doing historically. So the treatments we currently have are addressing the inflammation in the periphery or in the blood flow outside of the central nervous system. So this would be a shift in how we're treating and a shift in what we're targeting. And so that is what the MS community is really beginning to get excited about is, are we going to see a big impact by changing the targets of how we are addressing inflammation, and how does that impact this question of smoldering inflammation, this question of PIRA? Can we begin to reduce that inflammation on that drawing that you showed, that smoldering inflammation? Can we begin to take that down, and how does that translate to how patients function day in, day out? And those are, am I allowed to say the name of the therapies? I forgot.
Yes.
Okay.
Yes,
The Yeah. So BTK inhibitors are what those are called. The Bruton tyrosine kinase inhibitors is that class of medications. And that's the next class of medications that we're hoping we will be seeing sooner rather than later and able to offer patients. And so that's our next thing that we're looking forward to as far as therapy is concerned.
So as we wait for that new frontier,
Mhm.
I'm curious about all the ways that we can help people in addition to those medications. So this graphic here has many different factors on it. You've already talked significantly about age, but what about overall wellness? What are some of the other factors, whether it's related to diet or physical activity or comorbid health conditions, that you really focus on with your patients? Gabe, you want to describe?
Absolutely. So the concept, the essential concept is that we are pursuing brain health. We're pursuing health in general, right? I mean, we need healthy bodies, otherwise things are not going to go well. But in the case of MS in particular, we're thinking about healthy brains, because anything that happens to the brain is going to compound the problem. So to complement and kind of put things in perspective, earlier on, we talked about how we have this acute inflammation that is driven by the peripheral immune system. And Marie just introduced the concept of perhaps the smoldering inflammation is different in its process because we have come to recognize that is driven by a different type of cell, a cell that lives inside the brain, something that we call technically the microglia. Microglia are like the resident immune cells inside the brain, not the ones that come in and out from the bloodstream, but the ones that live there. And those seem to be the ones that perpetuate that inflammation and enhance that inflammation. Now, as this is taking place and we continue to chip away on the health of the brain, anything that we do to preserve the normal health of the brain is going to be extremely conducive to better outcomes. So imagine anything that you can do that might be affecting that in a negative way. So smoking, we know, has a negative effect on health overall, your lungs, but especially the brain in MS. Many studies have demonstrated very clearly that individuals with MS that smoke fare worse than individuals with MS equivalent to their disease that do not smoke. Physical activity does the same thing. Diet also is an area of great research and interest, and you're going to hear a lot of different opinions. But in general, a healthy diet is conducive to healthy state of well-being and a low grade of inflammation that is also conducive to trying to preserve the brain as much as possible. So a healthy lifestyle, healthy diet, exercise to your ability, being engaged intellectually and mentally is also creating all these connections and firing nerve cells in your brain. All of that is going to be important. I cannot emphasize more the fact that we need to approach this holistically. You are a single unit as an individual. We cannot separate your MS from everything else that is happening to you and anything else that you're doing for good or for bad in your brain and your body. So taking that approach holistically is what is going to result in better outcomes long term.
And are you seeing that in your own practices, Marie? I know we see it in the research, right? We know that a healthy diet, attention to mood, being socially interactive, getting physical activity, we know that people do better on the research outcomes in those studies. But just from a practical perspective, when you are working with patients and you're trying to talk about these lifestyle factors, do you find that people engage with them, feel ready to take on all those additional challenges in addition to managing their MS?
So this is the heart of what we do, right? Trying to meet patients where they are. And, I think readiness comes at different times for different people in different ways for different reasons, right? And so I feel like my job is just to continue to kind of reiterate and make information available. And when patients are ready, they know where to go. But I try on a very regular basis to cover the things that Gabe just talked about. We talk a lot about stress management. We had a conversation right before this began on how anxiety management is something that's always been a challenge, but I think post-COVID, it's been even more of a challenge. And managing stress, managing anxiety definitely impacts patients. I tell my patients, when you've got a lot of anxiety and stress going on in your life, it's like pouring gasoline on a fire. The symptoms you have are just going to get worse. And so we're going to really be kind of banging our heads against a wall, so to speak, if we're not trying to also address that underlying anxiety. I think sleep is something else I talk a lot about. Good sleep hygiene, really working on there's things that can help patients get good quality sleep. If you're not sleeping, we're really going to struggle with everything else as well. So all of these things matter. And, I never want to overwhelm a patient because it's really stressful if someone has a fairly unhealthy lifestyle to expect that they're going to overnight transition all that. I'll usually just say, what's the one thing you think that you can begin to work on? And how can I help you with that? And really try to begin to, okay, let's work on this. And then once we've kind of gotten that, let's move on to the next thing. Anything you're doing to improve your brain health should help with outcomes long term.
So I want to move us into our Q&A, but I just want to remind all of you that one of the reasons that Can Do MS wanted to have this webinar and wanted to work with these two wonderful clinicians is because we see the partnership between what the neurology provider can offer to you in practice, and how Can Do can also partner with you to help you identify the areas of your own wellness that you would like to improve, and offer strategies to help you get there. And our strategies involve coaching from healthcare providers, but even more importantly, coaching for each other. Because our programs all offer you the opportunity to do what you've been doing in the chat nonstop, to share ideas, resources, questions, and support as you work on your own wellness. So please join our programs to help you get where you want to be in your wellness as you work with Marie and Gabe to manage your acute inflammation and your smoldering MS. So Laura, I think we are ready to open up the Q&A.
Fantastic. Thank you all for all of that important information. Roz, I know that you have a number of questions. I did want to address a couple of things that came up. And the first one is labels. Everyone seems to be a little, there seems to be a number of folks that have asked, what is the difference between smoldering MS and progressive MS? Are they the same thing? Are they different? What about secondary progressive MS? How does that fit in? So there was definitely some confusion about labels.
Yeah,
it's because we're talking about different things. So when we talk about smoldering inflammation, we're talking about the mechanism of the disease, what is conditioning the problem. When we're talking about progressive MS or secondary progressive MS is more like what we see, what we call the phenotype. So we traditionally have divided MS into different phenotypes. Phenotype, fancy word to say, what does it look like? Well, some people have relapses, and then they get better and they have no problems. They have another relapse and they get better and they have no problems. Those we have classically called relapse and remitting MS. And as we've been discussing, that represents acute inflammation. Some other folks over time, it becomes evident that they have progression, even though it's been going from the get-go. It's just that it was not evident, but it's been building up. But once that progression, which we believe is driven primarily by smoldering inflammation, not exclusively, becomes more evident, then we just happen to call it secondary progressive MS because that's how it looks to us. So we're just referring to the same thing, but different components of the same thing. One is the process through which we get there. The other one is what we witness as patients or as physicians in the evolution of the disease.
And I think, if I'm understanding this correctly, we're going to see some change in vocabulary over time. I think the disease courses that we've been so familiar with for the last few decades are actually going to evolve as this understanding of the MS disease process evolves. So I think we all have to bear with the label confusion a little bit longer, right, until we know more about smoldering MS.
You're right. It's going to get worse, Ross, because because we hope, as clinicians and scientists, we hope that we could define MS more specifically by the biology. I mean, what is it that is happening to you, Peter, Paul, Mary? I get you. I understand your biology. What is happening in your body? Labels are labels for groups of individuals, and then they have pitfalls, right? Because we might not be understanding that well. So we have defined MS phenotypically, because that's what we had. How does it look like? We didn't have a lot of insight into the process. As we gain insight, we're going to redefine how that is being labeled. It's going to take time, but don't be surprised. Next month, actually, no, November, this month, there's going to be an international meeting that is going to redefine the diagnostic criteria for MS. So we're going to have to talk about that in short order, because something's going to start being shaken.
I think that we always have a lot of questions about aging. One of the reasons we've done some programs focused specifically on aging with MS is people are always asking, well, is this my MS or is this aging? And they're talking about memory, they're talking about other aspects of their mobility. And their cognition, and we often have to say to people, you're not ever going to be able to know exactly what is causing those changes. Is it menopause? Is it COVID, post-COVID? Is it chemotherapy from some other condition that you've had? And I think it's hard for people who want to understand what's causing the changes. But I think, could you comment again on the role of aging and why we think it is that so much of the progression seems to kind of speed up as people get older? Gabe?
Yeah, it has to do with several factors, but one important one that we have alluded to is the fact that we are decreasing the neuronal reserve naturally. The ability of the brain to compensate for problems is going down. And that is coupled or coincides with the evolution of the progression of damage from MS. So you reach a critical point, and it happens to be as you age that it becomes much more apparent. It's the reduction of the neuronal reserve, of the plasticity of the brain, the ability to compensate for deficits. I get a sense from just the scroll of all the comments that are coming through, there's a little bit of desperation about, well, it's kind of a little bit of more of the same. It's a different word for the same problem, and still we don't have solutions. I want to encourage people about this. Look, I think that we have come a very, very long way in our ability to treat MS. We have made great strides. The MS that we see today, as we treat it, and we treat it early and effectively, it is much different in its evolution than what we were doing 10, 15, 20 years ago. Our outcomes are so much better. But we are not content with that, because we recognize that there are problems, and we are working hard at identifying what else is going on. With the advantage, the result of that is not just giving it another name. Oh, now they call it a smoldering, so what? The result of that is that if we know that it's happening, we can come up with strategies to address it. And that is coming. And that is the excitement about all of this, is that once we know it happens, we hopefully are smart enough to come up with solutions for that. So if we recognize that we have controlled the acute inflammation from the periphery very well, but we're not very good at shutting down, even though we're doing some work on that with the current therapies, they do work on that, but not effectively for some. If we directly have an effect on the microglia activation and reduce that, can we then tackle this other problem that we're recognizing better nowadays? Yes, and it's at Portas. It is very close. We do not know what the results of the clinical trials will tell us. There are 5 different medications, as Marie was talking about, the BTK inhibitors, that were designed specifically to target that problem. because if we recognize that the microglia are the responsible cells, how can we tinker with the microglia so that they not continue to be active and inflammatory and damaging the brain? We have, we think, an answer, but we will not know until well-conducted, scientifically driven studies will prove to us that indeed that is the case and that it is safe. If it works and it's safe, then we'll be deploying that as a treatment that hopefully would address that problem as well. And it's very close.
So Marie, well, when Gabe says very close, what do you see as a timeline for people who, as Gabe says, are feeling, desperate about their MS and its progression? What kind of timeline are we looking at?
My understanding is late next year. I don't know, Gabe, I'm hearing late next year. Hopefully we'll begin to see FDA approval. But I want to go back to what he was saying, because I hear the desperation. I see the desperation. I feel the desperation in working with patients. And I wish I had answers right now. But to understand that we have got a completely new way of treating MS, it is really huge, right? Because a lot of our therapies we have really kind of focused on, the peripheral circulation, on the peripheral immune system. This is completely different. And with that comes new understanding. And so I just want to say, like, we're opening up a completely new area of treatment. And we don't have an answer for aging in and of itself, that the aging process, but there is inflammation that is part of that aging, those lesions we talked about earlier, that if we can make an impact there, that really does make an impact on how well patients do, and hopefully really slows progression. We'll see. But again, this is a big shift, and this is why it's really exciting, and for us to even talk about, or to be able to talk about and to introduce to everybody. So again, we're not quite there, but this is really an exciting new chapter that the MS community can't wait to begin to read, right? And see what we get out of it.
Well, and I think, it's easy to sort of dismiss some of the wellness strategies as, well, that's not really medicine for my MS. That's not what I need. That's just one more thing to worry about. But I think the three of us are in really strong agreement that those interventions that are sometimes hard to begin and hard to persevere with, like eliminating ultra-processed foods, fitting in exercise and physical activity every day, connecting with people, getting help with your sleep, all those things play an incredibly important role in how one lives with MS, how one thrives with MS. And we know it's not easy, but it has, in many ways, as much impact, different impact, but as much impact on a person's quality of life as all of the medical interventions. Or are you guys going to tell me I'm wrong about that?
No, not at all.
You're
Absolutely right, Ross. Look, as you were saying that, what came to mind? When we're talking about being healthy and kind of taking care of your body and getting to a certain age in better health, and how, of course, inexorable pass of time, you're going to age and things are going to be different, no doubt about that. But it has happened to every single one of you guys that were watching the news at night, and something comes up, and then someone did something bad, and the mug shot comes up, right? And there's this disheveled person with a beard and gray hair, and it looks wrinkly, and they say, this 45-year-old, like, 45? I am 50 or 55 and I look younger than that. Well, think about that in the brain. This person looks disheveled and not taken care of because they did not take care of their own body through processes that are related to healthy lifestyle, right? This is what it looks like externally. Same thing with the brain. If we're not doing things that are healthy, we're damaging the brain even more. We're damaging our skin even more. We're damaging our lungs even more. Those are visible, right? You cough or you look wrinkly. Well, the brain is the same thing. So anything that you do that is conducive to good brain health results in your brain looking handsomer, and that means that it's healthier, and that means that the effect of MS is going to be less. You have more healthy brain to compensate for the damage that MS brings to the table.
Somebody asked earlier on in the chat about the relationship between these treatments and NIDA. That the goal of no evidence of disease activity, how that fits into the thinking about inflammation, neurodegeneration, the new BTKI treatments that are going to emerge. So how does the concept of NIDA fit into this? Marie, go ahead.
I think NIDA is one of those concepts that has been a little controversial, shall we say, since its inception. And there's all different versions of NIDA that, people kept saying, well, if you look at no evidence of disease activity and you're just looking at relapses and MRI lesions, you haven't factored in cognition, you haven't factored in all these things. And so it's just a really challenging concept. But I think what I would also say, and Gabe was kind of alluding to this earlier, we're really completely shifting the way we're looking at MS as a disease process in general. And I think especially as we come up with, new ways to categorize the disease, new ways to label it, I don't know where NIDA will fit into that, but I also have never been a big fan of NIDA personally because, really for this reason, because we would have patients who would look really good in these categories, and yet this category was still a problem, right? And that's a lot of the kind of stuff we're talking about today, this PIRA, this really, this little bit of just really insidious, subtle progression that was occurring. So that's my take on it. Gabe, I don't know if you have a different take on it.
No, it is the same. I think NIDA is idealistic, and it's what we would like to get, right? No evidence of disease activity. Well, of course, I want to have no evidence of my disease being active, but how do we define it? What are we looking for to say, yes, it is not active or it is? So when we initially defined NIDA, which now is called NIDA 3, meaning there's 3 components to the evidence of no evidence of disease activity. As you were mentioning, Marie, do you have relapses? Do you have changes in the MRI? Do you have progression? Progression measured in a very indirect way. Yeah. So no, you don't have it. You're doing well. Well, not really. So can you have NIDA 4, NIDA 5, NIDA 6, NIDA 10, where we incorporate 10 elements, where we can incorporate, and this is a completely new topic, but how do we assess how patients are progressing? Very briefly, because I know that we're short on time. There's 3 buckets that we need to be looking into when we're assessing our patients. And there's a lot of elements within each bucket, but we need to bring them to the table. And we do this in clinical practice. When we're assessing our patients, we're discussing our approach to the treatment. 1, how are you doing functionally? What are your functions? Your walking, your thinking, your ability to do things, your dexterity. And we can measure that objectively with a lot of different tools. Cognitive tools, dexterity tools, walking time, things like those. We can put a number and see how you're doing. We can follow that. Bucket number 1. Bucket number 2 is imaging, usually MRIs, and MRIs continue to evolve. Do you have new lesions? Are your brain shrinking? Can we measure the volume of the brain? We'll be able in the near future to assess for the cells and the pearls that are indicators of the slowly expanding lesions that are creating this smoldering inflammation, are a representation of that. Bucket number 2, what does the MRI tell us? Bucket number 3, we have not talked about that, completely different topic. Biomarkers, fluid biomarkers, chemicals that we can identify in your blood or your spinal fluid that indicate the degree of inflammation or control of the inflammation that will tell us we're doing a good job or not. So once we accumulate evidence from each one of those in Peter, in Paul, or in Mary, we can tell Peter, Paul, or Mary how your MS is doing, and are we controlling it, and what else we need to do so that we have better outcomes.
Awesome.
I'm going to jump in quickly because we did have a number of questions about the octave test. And since you brought out that bucket 3 about the blood test, can you comment on that, Gabe, and give us some information about that test?
Yes, so the Octave platform is essentially something that is trying to do what I just referred to, a series of fluid biomarkers that indicate the control of the disease. Either you have active inflammation or even perhaps progressive inflammation or smoldering inflammation. This is a test that has been deployed, that is commercially available, that in my mind still needs a little bit more validation for us to be able to understand what it means and how to apply it to Peter, to Paul, or to Mary, so that we know what to do with the results, right? Now, the platform, in addition to that biomarker panel, is also incorporating elements from the other two buckets. The imaging buckets, they're looking at MRIs, and they're also doing some functional assessment, and not only functional assessment of the walking and the dexterity and things like those, but also, as Ross mentioned earlier, flash news, listening to the patients. How are you feeling? What's happening? How are you doing today compared to a month ago or a year ago? Are you better? Are you worse, right? But it's better if not only we chat about it, but can we put a number to it? So if we can quantify it and plot it over time, then we got a better sense. How do we do that? With tools called PROs, or patient-reported outcomes. These are questionnaires that have been designed and validated to measure something specific: fatigue, physical function, anxiety, and you complete these questionnaires, and as we see the numbers and we see the evolution, then we understand how you're progressing. So we're listening to you, but we're putting a number to what you're telling us so that we can objectively measure it over time.
And we've already had a few people say that we need to do another program like this because this is interesting and we need more information. So thank you both for helping us all understand this important topic.
Thanks very much, Roz. And a huge thank you to Marie and Gabe. So thank you for joining us this evening. This was an important webinar with some very important information. So with that, I am going to share my screen again and just let you know that stay connected with us. Roz talked about joining other Can Do MS programs. You can find a lot of information about that on our website. I do want to thank our sponsors. And I will ask you all to complete the survey that pops up on your screen after the webinar. So thank you to our panel. Thank you to our participants for joining us this evening. I hope you all have a wonderful evening, and I hope to see you again at another Can Do MS program.